So welcome to the Association of Black Cardiologists webinar at the center of the matter, Unmasking the Invisibility of COVID-19 in Diverse Populations. We are honored today that you are joining us at this challenging time. I want to extend a special welcome to our diverse membership, including our healthcare workers and community partners who are burdened with unthinkable responsibilities currently. I want to thank our speakers, Dr. Peter Chin Hong, Dr. Narissa Hayes, Dr. Kevin Alexander, Dr. Lisa Cooper, and Dr. Mike Ibarra, who have generously put in extra time despite frontline busy clinical responsibilities to present this webinar. I will introduce each speaker prior to their respective segments. I also particularly thank our CEO, Ms. Cassandra McCullough, our board chair, Dr. Elizabeth Affili, and our staff, Mr. Alan Merritt and Ms. Rachel Williams, for helping to make this webinar possible. Indeed, the COVID pandemic has in short order transformed all of our lives in a manner which for many of us has become deeply personal. The goal of our program is simple, and it is to provide you with clear, credible information about COVID-19, taking into consideration vulnerable groups, especially people of color. Our goal is consistent with the ABC mission of saving the hearts and minds of a diverse America by promoting the prevention and treatment of cardiovascular disease, including stroke in Blacks and other minorities, and to achieve health equity for all through elimination of disparities. We have had a long-standing efforts to address healthcare disparities, not only by sounding alarms, but also by incorporating thoughtful science into our clinical, community, and population level approaches globally. So here we are, sounding the alarm using data. I should first introduce myself. I am Michelle Albert. I am the president of the Association of Black Cardiologists. I'm a professor of medicine in the Department of Medicine at University of California, San Francisco. I direct the Center for the Study of Adversity in Cardiovascular Disease, or Nurture Center at UCSF. I'm also the Associate Dean of Admissions. So certainly, today's headlines show a perfect storm. This is a headline from the Huffington Post from today, showing that the COVID-19 virus is killing Blacks at alarming rates. Certainly, if you've paid attention to the news reports within the last 24 hours, this has been everywhere. As we look at United States emerging data unmasking the interplay of race, ethnicity, and COVID-19, we see that all across the country, as testing rates increase, the cases among racial and ethnic minorities are alarming, and most alarming are the fatality rates of Blacks and other minorities in the population. So for example, in LA County, whereas the Black population is 9%, the fatality rate is 17%. In Louisiana, population 32%, fatality rate 70%. In New York City, there are new data this morning showing the fatality rate among Hispanic and Latinos and African Americans outpacing their population representation in New York. So at a 35,000 foot level, what might be the reasons for these disparities? We believe access to care, disproportionate burden of comorbidities, including cardiovascular comorbidities, asthma, COPD. We believe discrimination and bias There's potentially biological mechanisms. However, we do believe that disproportionate burden of comorbidities, cultural factors, access to care, all represent major pathways through which we get to these disparities, which are consistent with disparities we see in most of our health conditions, wherein US racial and ethnic minorities, especially Blacks, have lowest longevity and highest rates, for example, of cardiovascular disease. Another component that we need to think about as it relates to the COVID epidemic is the impact of segregation. Segregation will act as a core pathway through which we see overcrowding, we see limited access to care, we see inability to adhere effectively to medical advice, including advice about social distancing, which I know that several of our speakers will get to during this presentation. We have neighborhood crowding, among other factors. So keeping this in mind, at the heart of the matter for us today is to take you through a series of short presentations that cover the epidemiology, the virology, the clinical, diagnostic testing, prevention, social determinants, and advocacy aspects of the COVID-19 epidemic with a robust discussion about diverse populations. Given this background, I would like to introduce our first speaker. Our first speaker would be Dr. Peter Chin Hong, who is an Associate Dean for Regional Campuses and Professor of Medicine in the Division of Infectious Diseases at the University of California, San Francisco. He is currently actively involved in the clinical care of COVID-19 patients. He was born and raised in Trinidad and Tobago. Before moving to the United States for undergraduate and medical school at Brown, he completed his residency in internal medicine and infectious disease at UCSF. Dr. Chin Hong.
Thanks a lot, Dr. Albert. It gives me a great honor and has a lot of meaning for me personally to present this data today and to be part of this national conversation. I would say locally in San Francisco, we have seen an outsized number of admissions from Latinx in particular and other minority populations in our hospital system at UCSF. So it's no surprise to me personally that as the data gets disaggregated that we're seeing this here today. So first I'd like to just start off just to bring everybody up to the same page on what we're talking about. So there's a difference between the virus and the clinical syndrome. So the virus that causes COVID-19 is called SARS-CoV-2. And there are other related coronaviruses that cause very similar syndromes. The most famous one, of course, being SARS a few years ago, was noticed in Hong Kong and later spread regionally, but not quite with the large reach that we're seeing today. So again, virus is SARS-CoV-2, disease or syndrome is COVID-19, similarly to how we think about HIV as a virus and AIDS as a syndrome. So our talk today, our conversation today will weave through these various sections, as Dr. Albert has said. Let's first start with epidemiology. But before that, just a little bit more about the history of coronaviruses. Again, we're talking about COVID-19 today, but these coronaviruses have been rogue for quite a few years. They're RNA viruses, and they've been circulating among humans and animals for quite some time. So of course, we heard about SARS back in 2002 in China, coming originally from bats. There was MERS from 2012 on the Arabian Peninsula, thought to have camels as a reservoir with 34% mortality. And then, of course, we're talking about SARS-CoV-2 virus causing COVID-19, which is our present outbreak. So coming back to the history, COVID-19 was first identified in China in a market in Wuhan in early December 2019. And again, we were very confused when we first saw it because there were these clinical presentations looking very similarly to ARDS. And we weren't really sure how much human-to-human spread there was. But of course, later on, we saw rapidly this was spreading. So how is SARS-CoV-2 spread, the virus that causes COVID-19? The main way that it's spread is through droplets. So that means that it's going from the nose or mouth of an individual into the nose or mouth of another individual. So that's really the main way it travels. And that droplet is heavy. SARS-CoV-2 is lazy, so it's going to fall within 3 feet of where the droplet lands. That means if you stay 6 feet away, which is a recommendation, you can escape it. It's kind of like you having a force shield around it. Of course, we, in the hospital setting, would do contact precautions. So that is a surface like your clothes. You want to just prevent the droplet from falling onto your clothes as a surface. And we'll do airborne precautions, which we normally do for viruses or like measles or other infections like tuberculosis, but which is not a normal way we protect ourselves in general from SARS-CoV-2. We normally use airborne when we're doing invasive procedures like intubation or bronchoscopy, where we can make aerosol from these droplets. I explain to my medical students, like, you're giving the droplets superpowers in these procedures. So you want to give yourself a little bit more protection. Most importantly, what we've learned over the last few months, well, actually about the last month or so, it seems like it's 10 years ago, but every day in COVID-19 is like a week or a month, is that asymptomatic patients are a big reservoir of spread, we think, in the community. SARS-CoV-2 is very different from the original SARS. People spread infections before they know that they're ill, as opposed to many infections that we know when people start spreading after they're very sick. And this is very important when we think about community spread. And it's estimated that about 15% of people spread this way. So when I first started giving these talks, back on March 8th, you can see that the global burden wasn't that high. It was about 107,000 cases with about 4,000 deaths. Today, when I'm giving this talk, you can see that we've had a striking increase in the disease burden across the world. And from the Johns Hopkins map, you can see a lot of red all over the world, attesting to how much this is a global pandemic and how much we really need a unified response, with about 76,000 deaths. When we zoom into the United States, of course, we see very hot spots, particularly on the East Coast and in the Midwest and in the South, where there's a large proportion of minority populations. And when we think about who dies, we reviewed the first 3,000 cases, and you can see that the main mortality is really above age 80, with about 15% mortality. So these are people who die when they have infection. And as you go down per decade, you can kind of think about it as dividing by 2. So say it's 8% between 70 and 80. You divide it by 2, it's 4% between 60 and 70, then 2% between 50 and 60. It's really above 50, but particularly around 80. Above 80, that's when we see the peak mortality. But let's unpack this a little bit more. So when we think about who else dies with COVID-19, we're really talking about comorbid conditions. So those with hypertension, diabetes, and cardiovascular disease in particular have an outsized case fatality rate, even given age. And I'd also like to mention that in the early Chinese data, more males were dying compared to females, but that was thought to be confounded by, or a little bit confounded by smoking, which is more common in males in China. We know when we think about minority populations, particularly African Americans, that that they have highest awareness and treatment rates of hypertension, above 75% of the population. But despite this, have among the lowest control rates, which is about less than 50% from the data that we know. And as Dr. Albert already showed you, there's striking data now around the country. And these are places, and it's important to know this, that we don't have national data. These are only places where they've disaggregated the data and give us data by race and ethnicity. The CDC has not done this. I was thinking of showing you a CDC epidemiology that they've released a week or two ago, but it wasn't meaningful to me because it just showed you, they just lumped everyone together and strikingly didn't include race and ethnicity breakouts. But as more and more regions are doing this, I think we're getting a bigger glimpse of what is going on around the country, particularly as Dr. Albert said, when you take populations that have anywhere from 15 to 30% population African Americans, when you look at the mortality rate of up to 80% in Milwaukee, Wisconsin, for example, and then today, getting the slides from New York showing you that in a really sophisticated breakdown by race ethnicity that's age adjusted, that there's an outsized impact on African Americans and Latinx populations. When we look at the Africans around the world, particularly in Africa, we don't see such a burden of disease, but I think this is due to several factors. One being the lack of availability of testing, but secondly, and probably most importantly, these countries in Africa and the Caribbean where I'm from, they've instituted really unified public health responses to COVID-19. In my own country, Trinidad and Tobago, they closed off the airspace. Everyone is doing social distance. They've closed down bars and rum shops, and they've done that from the beginning, and all the population is acting as one. I'm actually very sure that our patchwork approach in the United States is not adequate. Thank you.
So our next speaker will be Dr. Kevin Alexander. Dr. Alexander is an advanced heart failure and transplant cardiologist at Stanford University. He completed his internal medicine residency at Johns Hopkins Hospital, cardiology fellowship at Brigham and Women's Hospital, and advanced heart failure fellowship at Stanford. His research interests lie in improving the diagnosis and treatment of heart failure in diverse populations. Dr. Alexander.
Thanks, Dr. Albert. I'd like to thank the ABC for the opportunity to speak to you today. My talk is going to focus on the pathogenesis of SARS-CoV-2, as it's important to understand some of the fundamental mechanisms of disease to put into context the clinical manifestations as well as potential therapeutic targets. So as Dr. Chin Hong discussed in his presentation, SARS-CoV-2 is a RNA coronavirus. I'm not going to go into too much detail about the structure other than to point out that the spike protein, the spiked S proteins are key for the entry of the virus into target cells. This is the mechanism for viral entry for SARS-CoV-2. As I mentioned, the spike protein from the virus interacts with host cells via the angiotensin converting enzyme 2 receptor. And this interaction ultimately leads to viral entry and subsequent replication. A lot of this process happens in the lung pneumocytes because that's where there's a high expression of ACE2. And I think this interaction with ACE2 is important to consider given the biologic relevance of this enzyme. Just as a review, this is a key component of the renin-angiotensin-aldosterone system, and I'll review that briefly here on the right side of the slide. So angiotensin 1 is converted to angiotensin 2 through the ACE enzyme, and angiotensin 2 subsequently combined to angiotensin receptor, and that leads to a lot of downstream deleterious signaling such as inflammation, vasoconstriction, and fibrosis. This pathology is relevant to a number of cardiovascular diseases, and thusly we target this pathway with inhibitors of the ACE enzyme, as well as blockers of the angiotensin receptor to treat diseases like heart failure and hypertension. There's been some preclinical and in vitro data to suggest that inhibition of this pathway with ACE inhibitors or ARBs may increase the expression of ACE2, and then that theoretically would increase the rate of interaction of the virus with host cells, potentially increasing the pathogenicity of the disease. So I think with any with any disease, it's important to think about how biological mechanisms that vary by race can impact the pathogenicity of the disease. So what I show here is not necessarily a well delineated biological mechanism at this point, but I think highlights an example of how we should holistically think about how these diseases can affect individual subgroups differentially. So we know that there's significant variation in ACE2 expression by race. There's a number of variants that have been described in the literature, including a publication out of China recently that showed that variants in ACE2 can lead to increased or decreased expression of ACE2. We also know that there's racial variations in the activity of the renin-angiotensin-aldosterone system that varies by race. And so thusly that could also affect ACE activity. And so I think as we delve into more of the biology of this disease, this is an aspect that we should further explore as a scientific community. The other question that's come up a lot among patients as well as the medical community is, given this theoretical risk of increased ACE2 expression in those taking angiotensin receptor blockers or ARBs, should these medications be discontinued? And a number of leading cardiovascular societies have released a statement on this a couple of weeks ago. And the conclusion is that there's no robust experimental clinical data to date to warrant the discontinuation of these medications in people currently taking them. And so the HFSA, ACC, AHA currently recommend continuing these antagonists in people that have indications for them, because we know the potential harm of abrupt discontinuation of these drugs, say for a heart failure patient, for example. So I'd like to get back to a little bit to the expression of ACE2. Let's see. Sorry, we'll try to advance the slide here. Yep. I think, as I mentioned, ACE2 is highly expressed in pneumocytes, and so that's why the lungs are an important point of entry for the virus. But it's important to also remember that ACE2 is expressed in a wide variety of tissues, as shown on the right. There's a lot of ACE2 in the gastrointestinal tract, as well as kidneys, liver, pancreas. Many tissues have this, and that also likely explains the heterogeneity in clinical manifestations that we see. So these are some of the symptoms that have been reported for COVID-19 infection. These are recently published data from Wuhan, China, where they reported the presenting symptoms of over 1,000 patients. And you can see the most common symptoms are fever, cough, and fatigue, but there's a number of other symptoms that a fair number of patients can have, including myalgia, sore throat, and gastrointestinal manifestations. More and more, it wasn't published in this study, but there's been increasing recognition that there's other symptoms that can be associated with COVID-19,
Down there and say something.
smell and taste, and eye pain, and conjunctivitis, which I think bores further investigation, understand the pathogenesis of this.
Did you see it?
Let's see, maybe I could get some help advancing the slide. There's a little bit of a lag. So some of the common, let's see. We go back to the next slide. Yeah, thanks. Some of the common clinical manifestations of the disease that we see on diagnostic testing, it's been well characterized that lung findings on radiographic imaging are pretty common. So many patients will have abnormal CT findings, lung CT findings, and that can be a variety of abnormalities, including ground glass opacities, lobar consolidations, and a variety of patterns, often kind of in the periphery of the lung fields, interstitial lung findings as well. From a laboratory standpoint, many patients will have a relative lymphopenia, even in those that have a normal total white blood cell count. Many patients will have a decrease in the overall lymphocyte count. And then markers of inflammation are often elevated. Next slide. So I'd like to conclude with this slide, as I think it will help set the stage for the talks that subsequent talks you're going to hear from Dr. Haynes and Dr. Chin Hong. When we think about the infection, the early stages of the disease are driven by the viral replication and the target cells. So viral entry into the lungs and other host cells can lead to a lot of the fever, cough, GI manifestations that we see. But it's clear that in a subset of people that there's progression of the lung manifestations, and patients can develop a brisk inflammatory response that leads to another set of pathogenesis. And so I think that's important to keep in mind as we think about therapeutic targets for this. And so I'll turn over to Dr. Haynes now. Thanks for your attention.
So our next speaker will be Dr. Peter Chin Hong again. And I just want to say, for those of you, the chat has been hacked. So we're in the process of shutting down the chat, and we will continue to proceed with our presentations. So Dr. Chin Hong, please continue on as we talk about COVID in diverse populations.
Actually, it's Dr.
I'm sorry, it was Dr. Narissa Hayes. I apologize. So our next speaker is Dr. Narissa Hayes, who's the ABC Fellow representative to the board. She's currently a cardiology fellow at University of Pennsylvania. She attended medical school at Columbia University in New York and got her MPH at Harvard School of Public Health. She has worked in Haiti prior to her fellowship, and her interests include global cardiovascular health, behavioral cardiovascular health, and implementations research.
Hey, thank you very much, Dr. Albert, for the introduction. I will be focusing on the clinical manifestations of COVID-19, as well as the cardiac complications. So as Dr. Chin Hong highlighted earlier, there are a few epidemiological risk factors that I would like to focus on that are risk factors for severe COVID-19 disease. One is age, specifically age above 55 years old, chronic kidney disease, diabetes, hypertension, cardiovascular disease, including coronary artery disease, as well as cardiomyopathy. Immunosuppression is also a risk factor, and of note, elevated troponin is closely associated with poor prognosis in patients who are infected with COVID-19. So many of the risk factors that I just highlighted have varying prevalence among different groups in the United States population. So if we take a look at hypertension, for example, the prevalence is highest among African Americans. So for adults older than 20 years old, the prevalence of hypertension is 42%, followed by a high prevalence in Latinos of 29.4%. If we take a look at diabetes, the prevalence is highest among Latinos at 21.5%, followed by African Americans at 19.6%. And similarly, if we look at obesity, the prevalence of obesity is highest among African Americans at 47.5%, followed by Latinos at 46.9%. And it's not indicated on this slide, but it's also important to note that the prevalence of chronic kidney disease as well as end-stage renal disease is higher among African Americans. African Americans make up about 35% of patients on dialysis and only represent about 13% of the US population. African Americans also have a higher prevalence of cardiovascular disease and are more likely to die of cardiovascular disease. So as you can see in this chart, mortality rates due to cardiovascular disease have decreased for all racial groups. However, disparities in mortality due to cardiovascular disease persist. So as you can see here, African Americans die at a higher rate due to cardiovascular disease with a rate of 208 deaths per 100,000 people. Next slide, please. So to highlight again the three phases of COVID-19 infection that Dr. Alexander introduced, I would like to focus on the latter half of stage 2 as well as stage 3. And both of these stages are characterized by the host inflammatory response. So an article that was published earlier this year from China beautifully outlines the clinical course of COVID-19 among survivors and non-survivors, as you can see here. And if we superimpose the three phases of the COVID-19 infection, what we can see with the first phase is characterized by fever and cough. The second phase, which is the pulmonary phase, is characterized by dyspnea. And then stage 3, which is the hyperinflammatory phase, is characterized by acute kidney injury, acute cardiac injury, as well as severe ARDS. So taking a look at these two charts and comparing them, it's suggestive that the difference between the survivors and non-survivors has a lot to do with the hyperinflammatory phase, or stage 3. And the immune response specifically. So for example, if someone's immunosuppressed, they're more likely to die of COVID-19, possibly due to worsening sepsis or superinfection. At the same time, if someone has a hyperacute hyperinflammatory response, they're more likely to have severe ARDS, severe cardiac injury, and may also have acute kidney injury as well. So what are some of the cardiac complications that have been described in the literature? There are quite a few that have been described with COVID-19. The most common is acute cardiac injury, which is defined as an elevated troponin, specifically high sensitivity troponin with a level greater than the 99th percentile of the reference range. And this is an independent predictor of mortality. Myocarditis and cardiogenic shock has also been described in a number of case reports, both from China and here in the United States, and is also associated with high morbidity and mortality. Acute coronary syndrome, also known as a heart attack, as depicted here, has been reported, anecdotal reports of acute coronary syndrome. We do know, though, from prior studies that the incidence of myocardial infarction with viral illnesses such as influenza does increase as well. Arrhythmias have been well characterized in COVID-19, especially in severe COVID-19 infection. Common arrhythmias that have been described include high degree block, heart block, as well as ventricular tachycardia, ventricular fibrillation, and atrial arrhythmias, and are a significant cause of mortality as well in patients who have severe COVID-19 infection. Stress cardiomyopathy, which is also known as broken heart syndrome, has been described as well. And this makes sense, especially considering phase 3, that hyperinflammatory phase with a high cytokine state. And lastly, thromboembolism. There's a theory that COVID-19 causes hypercoagulability, and there are case reports from the United States as well as autopsy reports from China describing DVTs and pulmonary emboli in patients with COVID-19. This slide again just reiterates the significance of an elevated troponin. And again, cardiac injury is defined as that elevated high sensitivity troponin. And as you can see here on this slide, patients who have cardiac injury or elevated troponin have decreased survival or higher mortality compared to those who do not have a high troponin. And the hazard ratio in this study was 4.26 for patients who had an elevated troponin. So to illustrate how COVID-19 can manifest specifically in terms of cardiac complications, I'll just briefly present a case that was published from China of a 37-year-old gentleman who presented with 3 days of shortness of breath, chest pain, as well as diarrhea. He was hypotensive on presentation. He had ST elevations on his EKG, which you can see here, especially in the inferior leads, and you can see there's a significant difference from the baseline. His pulmonary imaging showed a right-sided pleural effusion as well as some ground glass opacities. His cardiac biomarkers were elevated. He had an elevated troponin as well as BNP. Due to the elevation in his biomarkers and the ST elevations on his EKG, he did have a coronary CT angiogram, which was negative for obstructive CAD. His EF was reduced, his ejection fraction was decreased at 27%, and he also had right ventricular dysfunction. He was managed with inotropes and conservative management and eventually did improve clinically. Okay, so I would like to thank Dr. Chin Hong for providing this echo image, and if I can see if I can play it. Try to go back. Is there any way we can try to play the video? Assist me in that. That'd be great. If not, we can move ahead. But this was posted on Twitter as an echo image of a patient who presented with a fulminant COVID-19 myocarditis, and the images were pretty impressive, illustrating severe biventricular dysfunction as well as large thrombi in both the left ventricle and the right ventricle. So I highlighted a number of cardiac complications due to coronavirus or COVID-19, and I would just like to highlight some of the hypotheses for why these complications occur. So first is this theory of hyperinflammatory state or systemic inflammatory response syndrome, characterized by high cytokines, high levels of cytokines, which can lead to cytokine-induced plaque rupture or disruption of unstable plaque, which subsequently leads to acute cardiac injury or myocardial infarction. Another hypothesis is that due to severe infection, there's increased metabolic demand, but also due to the characteristic severe hypoxemia of severe COVID-19 infection, there's severe oxygen supply demand mismatch, leading to cardiac ischemia, and again, leading to acute cardiac injury. Another hypothesis is that the virus itself can infiltrate or invade the myocardium, or because of the robust inflammatory response can lead to myocarditis. And lastly, there's some postulation that COVID-19 causes a hypercoagulable state, which can lead to microthrombi as well as more overt thromboembolisms such as DVTs and PEs. And again, I think highlighting some of the proposed pathogenesis pathways shows you that people who already have underlying cardiovascular disease are more likely to have worse outcomes. So how can we characterize patients who have severe COVID-19 disease in the United States? So this study was published by the CDC, and it characterizes patients who tested positive for COVID-19 between February 12th to March 16th. And of those who tested positive during that time period, a range, about 20 to 30% required hospitalization. Within that group, 4.9 to 11% required ICU admission, and the case fatality ranged from 1.8 to about 3.4%. The best study that characterized the prognosis of critically ill patients came from the United Kingdom and was published not too long ago. And they looked at 2,249 patients who were admitted to ICUs across the UK. And I think some of the findings were interesting. So we see some significant gender differences. We see that males were more likely to be admitted to the ICU compared to females, constituting 73% of all of those who are admitted to the ICU. And additionally, they broke down admissions based on race. And as you can see here, people who self-identified as Black in the United Kingdom accounted for 13.6% of all of the patients admitted to the ICU. And this is significant because according to the 2011 census for the UK, Blacks account for about 3% of the population in the United Kingdom. So again, they're disproportionately represented in this critically ill population. If we look at that critically ill population, those who are admitted to the ICU, we can take a closer look at those who required advanced respiratory therapy, which was defined as needing to be intubated. Again, we see that the gender disparity persists, with men being more likely to be intubated. And then also, Blacks accounted for 17.8% of the patients who were intubated. So again, this is significant, and they're disproportionately represented in this extremely critically ill patient population, especially considering that they're only 3% of the population of the UK. And this, of course, has implications for mortality. So in this study, they looked at the mortality among patients who were intubated compared to those who were not intubated in the ICU. And as you can see, those who were intubated had a very high mortality rate. 67.3% of patients who were intubated died, compared to only 16.3% of patients who required critical care but were not intubated. So that's pretty significant. So in summary, we have set the stage for who is at increased risk of severe COVID-19 disease. Vulnerable populations such as the African American community, because we know that they have a higher prevalence of risk factors. We also outlined the pathogenesis and clinical presentation of severe COVID-19. Based on the data that many of my colleagues have already mentioned, we know that vulnerable populations are being disproportionately affected by COVID-19. Due to this, we need more data on how populations of color are being affected by COVID-19. And I would argue that we also need to focus on how resources are being allocated and addressing inequities in resource allocation. For example, there has been wide media coverage of shortages in ventilators in certain districts as well as in certain states. And because of these shortages, there have been a number of discussions regarding rationing of ventilators. I think for me, at least, this brings into question, are ventilator shortages also disproportionately affecting low-income or minority communities? I think it's also important, if we do get to the point where we're having serious discussions about rationing, that vulnerable communities are kept in mind. And whenever we're discussing resource allocation, health equity is paramount. It's extremely important and it should be a priority. Health equity, the concept of health equity is essentially ensuring that all people have the opportunity to be as healthy as possible. And in order to do that, we need to tackle obstacles to health, such as poverty, discrimination, job insecurity, housing, and lack of access to quality healthcare. Thank you.
Thank you, Dr. Hayes, for this amazing presentation. I think at this point, I'd like to address our audience to say thank you for being with us. We will continue to trudge on in bringing to you information about unmasking the invisibility of COVID-19 in diverse populations. It is apropos that Dr. Haynes just ended her presentation on the tone of discrimination and bias in healthcare. We will continue on with our next speaker, Dr. Peter Chin Hung, who will talk to us about diagnosis, prevention, and testing.
Thanks a lot, Dr. Albert, and thanks to all of you in the audience who've been giving us such affirmative and loving statements despite all the hate. We really appreciate it, and we're all in this together. So I'm going to talk about the next section, which is around diagnostics and prevention. So let's talk about two of the main diagnostic strategies that we're using right now in the United States and globally. The main one that people have heard about is really looking for the virus through RNA, and that's the swab tests and the machines that people have been talking about when you talk about testing. And that, coming back from what Dr. Hayes has talked about, and we wouldn't get into this a lot during this presentation, but there's been a lot of inequities in terms of the way that the testing has been distributed in the United States. It's really a scarce resource, so that people who can grease the wheels or people of higher SES can have access to these testing strategies. That's why some of the first COVID-19 cases in the United States were amongst those with celebrities, those who could have access to the testing. The other strategy that I think will have a lot of importance and it's emerging is the use of antibody testing. In antibody testing, we could potentially identify those who have been exposed to the virus, since sometimes people may not have symptoms. And by identifying those antibody response, we can maybe identify those who may be fit to go back into the workforce, take care of COVID-19 patients, and also into the business world as well. We can also identify individuals who may be altruistically interested in donating plasma, as that's an emerging therapy that I'll get into. One of the big issues around testing in the United States has been the way that it was rolled out. So initially, the WHO had offered the United States its own test, but the United States was interested in developing its own. But as folks have seen, when the CDC rolled out their initial testing, it was not done adequately, and it was a little bit hastily done. So they had to recall a lot of the testing back to the CDC. So what happened was a remarkable thing. The FDA then allowed local laboratories around the country to develop their own COVID-19 tests. So that means that places like UCSF, we developed our own tests, but that took time because we needed to validate that test first. So again, further introducing delay in the testing strategy and rollout in the United States. So these are the current tests that we have available, some of them anyway. Most of them, the top three, are based on finding the virus, which is kind of a snapshot. And the last one, number 4, is the emerging use of serology that we can discuss, but has a lot of implications of identifying those who've been protected. It's like having a force field around you, and then can go back into the workforce if we're going to be in this for a few months. I'm just going to turn my attention now to a few words on treatment. So the way I think about treatment for COVID-19 now is like the Olympics. We don't have any gold medalists because we don't have any randomized control trials for COVID-19 drugs. And it's kind of like teaching an old drug new tricks, because we don't have enough time to develop a drug from the beginning to the end, which can take up to 10 years. So we have to repurpose old drugs. So the most promising, which I would give a silver medal to currently, is remdesivir. It's a nucleotide analog. It was used originally for Ebola by Gilead, and it's been seen as a promising drug for COVID-19. So far, there are 5 randomized control trials ongoing around the world. Some of you may have seen this in your own centers. as well as a compassionate use program for those who don't fit into the randomized controlled trial. Again, this is a little bit inequitably distributed, and if you're a big academic center in a city, you may have access to this investigational drug, but otherwise you would not have access to it. The bronze medalist is a drug that most people have heard about from the president and others, hydroxychloroquine. It's also known as Plaquenil. It's used a lot by rheumatologists to treat rheumatoid arthritis. And in vitro, it looks like it has activity against COVID-19 or SARS-CoV-2. But again, no real robust clinical data, not even case series, so except some anecdotal reports. So I'm going to give it a bronze medalist. I think in terms of emerging therapies, the one that I think has a lot of promise is the use of convalescent serum. That is enriching a blood product with antibodies from those who have seen and recovered from COVID-19. And we use it we're probably going to start using it in the sickest patients first, but I think the best benefit will be in those where patients early in the disease have ongoing viral replication so that you can stop the virus in its tracks before it leads to that inflammatory response that seems to really cause the mortality. On the right side, I've listed a lot of other drugs that are under investigation, but they have not been as promising. I wouldn't put a lot of stock into it. The most recent, of course, that's getting some media attention is ivermectin, which is an anti-parasitic drug. But again, I'm not really sure how it will fit into the Olympics of therapy for COVID-19. This slide is reprised from what you've seen earlier from Dr. Alexander, and it's really speaking to when we might use drugs. But again, most of the antivirals, when we think about using them, are in the viral response phase, when you have ongoing viral replication and you want to stop the virus in its tracks. So either you stop it in its tracks with an antiviral like remdesivir, or you give it enriched plasma, convalescent plasma. So you give somebody else's antibodies to stop the virus in its tracks. In terms of the later phase of disease with the host inflammatory response phase, a lot of people are looking at various therapies in this realm. I didn't go into them too much, but they include IL-6 blockers, steroids, etc. And maybe they may be a place for this in the cardiac complications, but I think we need more data before we unleash these drugs willy-nilly, because we know from sepsis and when we use rational therapies like TNF-alpha inhibitors, it actually made patients do worse with sepsis. So I think we need to really be thoughtful and have data before we unleash these anti-inflammatory drugs in the later phase of disease. I'll speak a few words on prevention now. As I alluded to in the earlier part of the presentation, the way COVID-19 is spread, again, is on a droplet from somebody's mouth or nose into somebody else's mouth or nose. So protecting that mouth or nose from someone is probably going to give you the biggest bang for the buck. I find from questions raised from community members when I speak to them that there's a lot of confusion about thinking about everything in the same way. So I'm going to clean my iPhone and clean surfaces and rub my kitchen counter down, but actually maintaining social distance and maybe wearing a mask where you can't maintain social distance, like in a grocery or waiting for the subway, is probably going to be the biggest bang for your buck. In the hospital, we use the mask mainly. That's the main mechanism of prevention, but also we cover surfaces with gown and gloves, and we may also give ourselves eye protection. There's work on a vaccine ongoing, but that probably won't be around for 12 to 18 months. I think we're going to be in this for the long run. Experts think that COVID-19 is not going to go away. There'll be seasonal variation. And eventually, more and more of the population would have seen it. But again, it's not going to go away. We'll see it rise in the Southern Hemisphere for their winter, which is our summer, and then come back again in the winter time in the Northern Hemisphere. So this is kind of like a summary of the public health messaging that we and others have been giving the general population. We sanitize hands, wash those hands for 20 seconds, sing happy birthday twice, or whatever chorus you like, use hand sanitizer, use swipe surfaces, you maintain social distance for about 6 feet, but because again, the virus on the droplet will fall within a 3-foot radius. So maintaining 6 feet will kind of give you a cushion from where that droplet is going to fall. And of course, staying home if you're sick. But does that really apply to our minority populations? This is really intriguing data from the New York Times that was published a few days ago, showing that after the shelter-in-place guidelines were given in New York and elsewhere, those who were poorest actually had a delay in when they were able to have less movement. And that's not surprising to anybody in this audience. We do know that it's a luxury to stay home and work, and not everyone can afford it. It's a luxury to be able to have childcare, and not everyone can do that. So it's no surprise that when you institute a public health measure like stay home, not everyone can do that. And it's not that people are being disobedient. It's just that the realities of life do not permit this. Furthermore, we tell people to wash their hands, but what's really striking, and this is data provided by some of my colleagues, Kirsten Bivens Domingo and Mia Losada, who works in the Indian Health Services, that what is not really known by a lot of people is that there's a poverty map associated with running water, even in the United States. So you can see that in many areas of the country, people don't have access to running water. In fact, in San Francisco, in some of our poor areas, I was really heartened to see that yesterday, our Department of Public Health in the city put up portable hand washing stations in some of our poorer neighborhoods. And again, what is the metaphor around wearing face masks and in the public? I think this was really striking to me to see some of these kinds of messages posted by African-American individuals on social media, and I'll just read one of them. I do not trust that I will not be followed. I do not trust that I will be allowed to exist in my Black skin and be able to buy groceries or other necessities without a confrontation and having to explain my intent and my presence. Thank you for your attention.
Thank you, Dr. Peter Chin Hong, for that amazing presentation. Our next speaker will be Dr. Lisa Cooper. Dr. Cooper is a Bloomberg Distinguished Professor at Johns Hopkins School of Medicine and the Bloomberg School of Public Health. She's the James F. Fraze Professor in Medicine in the Division of General Internal Medicine and is a core faculty member in the Welch Center for Prevention, Epidemiology, and Clinical Research. As a general internist and social epidemiologist and health services researcher, she designs innovative interventions targeting physicians' communication skills, patient self-management, and healthcare organizations' ability to address needs of populations experiencing health disparities. Dr. Cooper was born in Liberia, West Africa. She is listed as on the Thomson Reuters top 1% of most cited for the social sciences several times, and she received a 2007 MacArthur Genius Award. Thank you, Dr. Cooper.
Hi, everybody. So I think I'm bringing up the rear on this session, which has been phenomenal. And I'm going to be highlighting some points that were made by some of the previous speakers as well. Michelle, can I advance the slides myself, or do I need you to do that?
Advance.
I'm not really sure how to do that, so maybe you can advance.
Dr. Cooper, you can click the slide.
Okay.
Advance with your right keyboard arrow.
Okay, it's not happening. No. Okay, if someone can just, oh, it looks like, nope, I'm not getting it. So if someone else can advance them for me, that would be great. So this slide is just basically reiterating some of the things that the previous speakers mentioned about the fact that we are seeing disparities in COVID infections and deaths across the US in several large cities. New York already reporting differences across several neighborhoods, highlighting the contribution of race and socioeconomic status to this pandemic. Next slide. So these again are the vulnerable disparity populations that we have basically on a regular basis. This is not even in the age of COVID, but just on a regular day, we know that racial and ethnic minorities and persons with low income are vulnerable populations. But add to that, we have homeless and housing insecure people, people who are immigrants, refugees, and displaced persons across the world, you know, people who live in low income countries, many of them disproportionately people of color. We have people who with disabilities who are at extreme risk on a regular day, but these are the folks that we're really concerned about at this point in time, because we know that they already experience a lot of challenges staying healthy or getting their health needs met. And with the COVID epidemic impacting people with chronic medical and mental health conditions at higher rates, we know our communities of colors are already disproportionately impacted. Next slide. So here are some of the social determinants of health. We've been talking about them. You know, the fact that a lot of people in our socially disadvantaged communities are lacking access to basic resources such as food and water, shelter, and transportation. And I was speaking to one of my patients recently who told me that she got on a city bus and was going to pick her medications up, and she has diabetes, you know, and I said to her, why did you do that? And she said, I had to go. I didn't have any other way of getting it, and I didn't want to impose on anyone. And so I did that. So, you know, we're hearing that people are making choices out of desperation. There are people who either are homeless or are living in apartments that are crowded with 2 or 3 families. We know that's the case for many immigrant families, and making it very difficult for them to engage in social distancing. Many people in our communities either don't have a primary care provider or lack insurance and are afraid to seek health care at this point in time because they might incur additional costs. Our communities are disproportionately the workers, people who are serving in service professions, people who are caring for other people, and are hourly workers and are therefore really working during the time when maybe some of us have the luxury of teleworking because they don't have a choice. They might lose their job or they may lose income if they choose not to work. Several of our communities don't have internet services or telephone services that would allow them to take advantage of telemedicine opportunities, and our children who home from school, many of them don't have access to computers that they can use to continue their education at this point in time. We're seeing an increase in the rates of domestic violence and abuse at this time, also a concern in many of our communities. And then of course, we have people in our communities are not unaccustomed to discrimination. You've heard about some of these statements. They are used to experiencing discrimination and are therefore mistrustful of a lot of what they're hearing through the authorities and may not actually even believe that they are at increased risk. Unfortunately, I read an article in the Baltimore newspaper yesterday where a police officer was engaging in some racist behavior, and the housing residents who were like his victims because he was basically spitting on them, they said, well, we're not even at risk. Black people don't get COVID. So we know that there are a lot of myths that are circulating and mistrust. And so this increases the problems and the challenges during this time. Next slide. So yeah, you heard about the fact that not everyone can work from home and the fact that social distancing is a privilege. This is an op-ed that was written in the New York Times, but it drew from some data from an economic report basically showing that 1 in 5 Black workers and 1 in 6 Hispanic workers are able to work from home, less than that actually. And that only 10% of workers in the lowest quartile of the wage distribution are able to telework, compared with 61% of workers in the highest quartile. So, and then basically in this op-ed, the writer said, if you touch people for a living in elder or childcare, if you cut or fix their hair, or if you clean their spaces or cook their food, drive their cars, or build their houses, you can't do that from home. And so we as a community, a lot of our folks are at increased risk for exposure, further exposure during this time, and for spread to those around them. And so frankly, that is probably why we're seeing the rates that we're seeing. Next slide. So, you know, we may be feeling overwhelmed at this time. It's like, what can we do about all of this? You know, some of these things, these things existed for a long time, and it's not like we can change them overnight, but there are some things that we can do in the immediate term. And a colleague of mine, Josh Sharfstein, and I just wrote an op-ed in Politico that was published yesterday, where we basically issued a call to action to a lot of policymakers around issues that they can do right now to help the most vulnerable at this time. And so we talked about things like expanding housing, so making dormitories and hotel rooms available for people who are not able to safely engage in social distancing in their own homes, providing food, additional food for people, supporting food pantries, extending SNAP benefits, things like that. Supporting educational endeavors like providing computers and laptops and supporting unlimited internet service for people who cannot afford to pay for it. Really protecting the workers, making sure that people who are doing these service and essential jobs are not forgotten. The custodial workers in the hospitals, they should have the same access to personal protective equipment that other folks working in the hospitals have. People should know that they have paid sick leave. They should know that they can get healthcare if they need to get it at this point in time. We need to expand healthcare access, make sure the healthcare exchanges are open for enrollment for people who lose their jobs or become furloughed or lose their benefits. Also expand Medicaid at this point in time. And really importantly, partner with trusted members of vulnerable communities. We've met with several community-based organizations that know where the problems are. They know what the needs are. They're used to providing services in these communities, and we should be working with them to problem solve and to make sure that people get their basic needs met at this time. Next slide. So I'm just going to close with a shameless plug for the Center for Health Equity resources page. We have an extensive list of resources to address social determinants of health for vulnerable communities and for the service providers who take care of them, healthcare and other service providers. So take a look at that website, and thanks again for allowing me to participate in this webinar.
Thank you, Dr. Cooper, for those great insights and for your presentation. We will proceed to our next speaker, Dr. Michael Ibarra, who is a board-certified emergency medicine physician. He currently practices at MedStar at Georgetown University Hospital. He's the president of medical affairs and strategic alliances at Pharma. And in that capacity, he leads stakeholder outreach on federal policy issues. Welcome, Dr. Ibarra.
Yeah, thank you. Thanks so much for having me. I really appreciate being a part of this panel and learned a lot from the other experts that were on. So thanks again for putting this together. As Dr. Hopper mentioned, I'm an emergency physician. I work at one of the local hospitals here in DC. When this wraps, I'm actually going to switch over into my scrubs and head in to take care of some patients this evening in the emergency department. We're definitely seeing a transition in cases. You know, we're used to seeing a tremendous diversity in the emergency departments, and the amount of volume that we're seeing has overall gone down. But the number of cases of COVID, you know, you wouldn't see, 5 MIs on a shift or 5, appendicitis, and yet about half the volume that we're seeing right now are patients with cough, fever, shortness of breath. And a number of them are testing positive for COVID. So there's a lot that we don't know about the virus, but the data coming out that the other presenters have presented about the impact on minority communities is very, very troubling. And there are a number of hypotheses that have been put forward as to why that's the case. Dr. Harris, the AMA president, last night was really eloquent on one of the news shows talking about how we need more data. And I think that is clearly very key. Obviously, the world is going to look very different when we have more data both on the virus, the impact that it has on communities, and also the efficacy of treatments. And working at Pharma, the trade association representing industry, I want to spend a minute talking about that. But before I do, just kind of dovetailing off the last presentation, it's also really important to note the impact that this is going to have on coverage. And in particular, the data coming out now that shows that there's going to be a significant growth in the Medicaid population as individuals lose their jobs and shift away from employer-sponsored coverage into Medicaid populations. The access restrictions, the access barriers that might exist because of state policies are going to be really important for all of us to consider. So it's something that we're keeping an eye on, and I think more data is going to be needed to really elucidate how we can best take care of our patients. From the pharma standpoint, we're working around the clock, as a number of presenters have mentioned, sponsoring clinical trials to investigate which treatments are going to be most effective for individuals impacted by this disease. First, a number of our companies are not just pharmaceutical manufacturers, but they have potentially lab and diagnostic testing arms of their companies. Even if they don't, one of our members, Eli Lilly, just recently announced that they are launching a major testing initiative in Indiana. They're turning their specialized research laboratory into a kind of dedicated COVID testing center. So they're helping Indiana healthcare facilities, including nursing homes and emergency rooms, run tests for the state there, and a number of companies are partnering with local jurisdictions. Second, a number of our companies have these vast global libraries of medicines that they can scan and identify which potential treatments may have in vitro effect against coronavirus. And some of them are available to patients right now, either through clinical trials or compassionate use, expanded access programs. There was a really good article on NBC News last week that looked at the kind of existing therapies that are already invented, potentially on the market, and how the data is coming out about those therapies. So just to bucket them in a few, there is investigation right now into some RA medications. One of the earlier speakers talked about the cytokine storm, the IL-6, the role that plays in the lung damage that patients experience. And so some rheumatoid arthritis drugs like Actemra is one that Genentech manufactures, is being studied in clinical trials now to investigate the impact that might have on some of the late-term damage that we're seeing. HIV medicines, given HIV is also a retrovirus, there's some mixed data out so far on that, but it is being looked at from the coronavirus standpoint. One of the previous speakers mentioned malaria medications. There was a large donation made by Bayer to the US government of hydroxychloroquine in order to be utilized in the study of hydroxychloroquine and COVID-19. And there's been some preliminary data and obviously a lot of public talk about that as well. But I think what we need again is more data. Finally, on the antiviral side of things is remdesivir, which is an antiviral medication that has probably been most widely talked about. It was originally developed to treat Ebola, and it has a good in vitro response. It's being studied right now in Washington, University of Nebraska. They just announced an expanded access programs for patients that are critically ill. Two other modalities that I want to mention and turn to some access barriers to wrap things up. The third kind of big bucket of research going on now is using plasma technology, new monoclonal antibodies to target the virus. Scott Gottlieb, who's the former FDA commissioner, has talked a lot about this technology and the potential that it could be deployed in the fall to protect healthcare workers and folks that work in the hospital to prevent transmission and more seating in hospital settings. And then fourth, of course, is the thing that we're most anxious for, but is the longer time horizon. That's the development of vaccines. And Moderna announced a phase 1 clinical trial is underway in healthy adult volunteers in Washington. Johnson & Johnson last week announced that they are ramping up production of a vaccine that's entering clinical trials now. So there's a lot of work going on in industry to bring these medicines to market. But of course, all of your practices are being impacted by it. The patients that we all care for are being impacted by the access barriers the patients are facing in the world of social distancing and shutdowns, the lack of transportation many patients have. And so Congress has looked to address some of these things through the several stimulus packages that they've passed. The third of which is called the CARES Act, the Coronavirus Aid, Relief, and Economic Security Act, that passed a little over a week ago and was signed into law. It included a number of provisions that promote beneficiary access during this public health emergency. So for example, coverage for COVID-19 COVID-19 vaccine would fall under the Medicare Part B benefit, B as in boy, and that would include no deductible or cost sharing for individuals that were obtaining that vaccine. From a provider standpoint, it also lifts sequestration payments for providers and increases the payment that hospitals are receiving for the treatment of patients with COVID vaccine. Again, a huge issue for providers right now is the change and shift in volume. It made expansions to telehealth coverage in cases of emergencies, including for hospice and home health care. And it also requires plans Part D plans, which is the coverage that covers medicines obtained at the pharmacy, as well as Medicare Advantage plans to permit Part D beneficiaries to get a refill or to fill up to a 90-day supply. And we're seeing some of that occur in the commercial market as well, and some Medicaid plans looking at that also, which is important for people that can't get to the pharmacy to be able to expand their access to the medicine. So there are other things that we know likely need to happen, and Congress is talking about doing additional stimulus packages. They're talking about a third, 3.5 package in the coming weeks, potentially a fourth and a fifth. There are a number of things that we're looking at, such as how do we make sure patients that get infused medicines still have access to those medicines, even though a number of infusion centers are either closed, shutting down, have restricted hours because of the outbreak. And then also, are there other things that we could do to lighten the burden on practitioners, like providers having to deal with prior authorization and utilization management in a world right now where there's this pandemic? There are just logistical hurdles to getting those things done. So as we look to the next stimulus packages, those are areas that we're going to be focused on, and would welcome working with you all on those issues. So thank you for having me to kind of provide this perspective of some of the policy areas that are being discussed from an access standpoint, and also to talk about the way that industry is engaging in these clinical trials and investigative medicines.
Thank you, Dr. Ibarra. And I want to thank our speakers for their outstanding presentations covering a range of topics, really diving into being focused on diverse populations. We are approximately 16 minutes over. We will continue to launch into our discussion section. For those of you who are able to continue to stay with us, we would gladly welcome you to stay with us. And for those of you who have to depart at this time, we want to thank you for joining us for this webinar about unmasking the invisibility of COVID-19 in diverse populations. I think that as the moderator of this session, or chairperson of the session, I'll take the first prerogative to ask the first question. We've seen a bunch of questions related to this. We know, and this question can go to either Kevin or Peter. Since viral load is highest early on, how important do you think asymptomatic spread is, for example, not only in adults, but also in children? And then also, there was a question from Erin Mikos at Hopkins asking about micro droplets and relationship to respiratory transmission of the disease in the community level.
Certainly. I can take that question if you like. In terms of the question on asymptomatic transmission, again, it's a very wily virus, very different from what we've seen before, and that's why I think it spread so quickly. Again, to recap, in regular infections, and certainly with the original SARS, people really spread after they started getting sick, so they can self-isolate. In SARS-CoV-2 that causes COVID-19, we know from population-based data in Korea in particular, where they did a lot of population-based screening, not like the United States, that a lot of the transmissions were spread, we think about 15% by people who didn't know they were sick. So in this infection, the viral load actually starts to rise before you actually get sick, and that's the time when people transmit infections. In terms of the question about micro droplets, I know there's been a lot of media coverage about this laboratory, that laboratory finding like random strands of virus wherever you look. I mean, it's like you look in the air vent, you'll find it. And I think it's important for us to keep our eyes on the prize. It's not that you can't find virus where you look for it. In fact, if I swab my skin now, I'd find MRSA, but it's not causing me disease. I think the bulk of the infection, it's about risk reduction. It's not about absolute 0 and 1. So to give the community a message that you're really going to prevent the biggest bang for your buck by doing these certain measures doesn't mean that you should be confused by this lab or that lab finding virus randomly. There's probably less aerosolization spread in the community, but mainly it's an issue in the healthcare field, in the ICU, in the emergency room, where you're intubating patients and you're giving these droplets superpowers, like the liquid in a hairspray bottle. When you spray it, that liquid becomes fine, small droplets or aerosolization. And that needs a little bit higher level of protection, which is an N95 mask. Otherwise, most times in the healthcare, you can get by with a surgical mask. In the community, of course, if everyone's masking in areas where you can control social distancing, like in the subway and Muni and the bus, in the grocery, wearing a bandana or a scarf or something to protect that nose and the mouth is probably going to give you protection because you're going to use it in addition to other measures.
Thank you, Peter. The next question is about what do we know about anticoagulation for COVID-19 patients? I'll give that question to Narissa. And I'll piggyback along with that question since you gave the clinical presentation. But what do we know about the long-term effects of COVID? Because anticoagulation does tie into that acutely as well as potentially long-term. And so what do we know about the long-term cardiovascular effects as well? So 2 questions.
Unmute.
So you're on mute.
Sorry, thank you. It's a good question. And I think currently many people are trying to answer that question. As I described, one of the hypotheses is that COVID-19 causes a hypercoagulable state, and there are case reports of MI as well as DVT and PE. To my knowledge, and I'd be curious if any of the other panelists know or are aware, there haven't been any sort of studies or randomized trials to look at anticoagulation in this setting. I've heard of, anecdotal cases of people using anticoagulation. I think obviously when you have definitive diagnosis of thromboembolism, it makes sense. And then unfortunately, I think the mortality in those patients is quite high. So in terms of the long-term effects, I don't think that's quite clear. I don't know if Dr. Chin-Hong, if you have any.
Yeah, so I think right now clinically, we're mainly doing anticoagulation if there's a regular indication. For example, we have currently a patient who had an unexpected DVT who came in with COVID-19 in the ICU. In that case, looking through a lot of PEs and then thinking about anticoagulation in that setting. I think as data emerge, it may be interesting if people see a subgroup of patients who may benefit from anticoagulation independent of the regular clinical indications, where you want to get that in early before something bad happens. And I think that's why the cardiology community in particular would be really helpful in terms of understanding which patients may benefit from this potential intervention.
Thank you. And Dr. Cooper, question for you about what recommendations would you give to our public health agencies, such as our transportation agencies, buses, trains, because in many cities, the routes are getting canceled or attenuated. And in fact, these are sources of transport for low income and racial and ethnic minorities. Any one of the other panelists want to take the question?
I can ask, I can mention some of the things we've been telling our community members. Again, it's all about risk reduction. So it's not, I know there's this, when you hear the public health message in some communities, like LA today, for example, said to all the population they should wear masks. It's not that not everyone can afford to take individual car transportation, but when you are in a crowded setting, you do want to protect your face and your mouth from that's the paradise for the virus. And whether or not, and you can't control social distancing, wash your hands and try to protect your face and your mouth with a mask, homemade mask or something like that. As somebody who can't not stay home and do work, somebody who has to continue to take public transportation.
Thank you, Peter. Kevin Alexander, any questions that you'd like to answer?
Yeah, we've gotten a lot of great questions, and so I'll try to consolidate some of the themes. So there's been a couple of questions about whether or not pericarditis is a presentation that can be seen with COVID. So I think that kind of falls along the lines of Dr. Haynes' presentation, that there's a spectrum of cardiovascular complications that can be seen with COVID, particularly when there's an acute inflammatory cytokine storm response. And so similar to other viruses like influenza, we can see a spectrum of myopericarditis, where either pericardial inflammation or myocardial inflammation or both are key components. And I think at this point, the management would be kind of similar in terms of how we would pick cases up and then treatment intervention. So we don't really have any great clinical data to date that I'm aware of that says that there's certain unique aspects to COVID-mediated pericarditis, but compared to other viral pericarditis, but that data will be important to delve into. And then another theme of questions that we've gotten, so patients with cardiovascular disease, so hypertrophic cardiomyopathy, or other forms of heart failure, what are some of the things that can be done to reduce their risk of infection, or if they do get infected, are there strategies to kind of mitigate the risk in this high risk population? As a heart failure cardiologist, we're confronted with this, and I'm confronted with this daily with my patients. And I think a lot of the keys still rest on decreasing or preventing disease. Just a sec. Decreasing acquiring the disease. And so, one thing that I think our healthcare center has done, as well as others, is really minimizing contact with the healthcare system. So, really transitioning to telehealth visits to decrease the number of times patients have to come into the hospital. Medication refill is kind of brought up by Dr. Cooper. How can we decrease the amount that our patients have to move in the public to get these things? So I think that is really the cornerstone, is prevention. But then once patients have COVID, I think we'd manage it similarly, but just without heightened awareness that they're at risk for, have less functional reserve to compensate for any kind of deterioration. So probably lower thresholds to be more aggressive about oxygen supplementation or closer monitoring of care.
I would add there too, Dr. Alexander, that reinforcing to our patients and community members not to discontinue their medications that have been prescribed to them by their healthcare practitioners. Certainly, there's been a lot of buzz a couple of weeks ago about the ACE inhibitors and the ARBs, and you presented elegant work about ACE as the mechanism, the ACE receptor as a mechanism for virus entry into the cells. But all medical societies at the current time recommend continuation of these medications.
So let's see some other questions. So maybe this would be for Dr. Hayes. So are there any clinical predictors that can stratify patients who may need ICU care or who may later go on to develop cytokine storm or ARDS?
Yes, so some laboratory predictors, again, troponin is a very strong predictor of patients who have a more severe clinical course with COVID-19. Again, it directly predicts mortality, and it's dose dependent. So the higher troponin is, the more predictive it is of a poor outcome. D-dimers as well. There are many studies that have shown that the more elevated a patient's D-dimer is, it can also be used as a prognostic indicator. And then, typical vital signs, if someone presents hypoxic with an oxygen saturation less than 90%, that's also a strong predictor that the patient will need to potentially be intubated. And then again, those sort of epidemiological risk factors and the severity of those risk factors. So if someone already has a severely decreased ejection fraction, that's a very poor prognostic indicator as well. But in terms of the labs, the most prognostic labs would be the D-dimer as well as the troponin. At this point, it's not recommended to trend at least the troponin, but it could be interesting to see if some therapeutics prove to be effective down the line, that perhaps we can use these labs such as like D-dimer and troponin to decide who gets certain treatments and who doesn't. But right now, it really is just an indicator of poor prognosis.
Okay, great. So I think we have time for just one more question. So I'll direct this one for Dr. Chen Hong. There's a question of, do we have for SARS-CoV-1, is there information about whether people can develop a durable antibody response? And is there any data for SARS-CoV-2?
Yeah, so I think the question always comes from colleagues as well in the community is, can I get this again? And what if I get re-exposed? Simply, especially since I told you that it's not going to go away, we think. There's good news. Actually, in SARS-CoV-2 with COVID-19, there was a nice study in monkeys. They gave them COVID-19, and then 1 month later, they tried to give them COVID-19 again, and they couldn't get it. And that's because of several things. The main thing is that unlike the common cold, which is caused by 300 different viruses, there's only one thing that causes COVID-19, which is SARS-CoV-2. And we don't think it has mutated a lot. And again, if you develop an antibody response to it, and we're not sure who does it, we think the sickest patients actually develop the most durable antibody response from preliminary data. And you basically develop this antibody response, you got sick, you probably won't get it again. So that's the bottom line. And that's the silver lining.
Excellent. We have our questions now, appropriate questions coming in fast and furious. What I will say is that we are at the half hour at this point, and so we will proceed with closing out our webinar. However, I'll say in closing, on behalf of the Association of Black Cardiologists, we thank you for joining us today. We hope that you choose to become a member of our organization. As you can see, that we are interested in the credible issues for solving problems. This webinar will be available on our ABC website shortly. Please stay tuned for other efforts, including an informational section on COVID, which will be managed by our COVID team and frequently updated, along with enduring manuscripts. We will do our part to help curb this pandemic, especially focused on our diverse racial and ethnic population through research, continuous learning, community outreach, and publications. Once more, I want to thank our speakers, Dr. Peter Chin Hong, Narissa Hayes, Kevin Alexander, Lisa Cooper, and Mike Kubara, as well as our staff and our CEO for helping to put this program together. I will end with one quote from Maya Angelou that says, "If you find it in your heart to care for somebody else, you will have succeeded." Thank you very much.